COVID-19 arrived in a world already divided by fake news, alternative facts, conspiracy theories, all of which were driven by social media, legacy media, and ignorant politicians. Highly respected scientists began to be censored. Now, after 18 months of data, COVID Chronicles can reveal what actually happened.
I first met Ivor probably 6-7 years ago after I released my first movie, Serial Killers. And Ivor was instrumental in the production of my last movie, Extra Time, which was filmed in Ireland. And in fact, he ultimately became a co-producer on that. I want to ask you a few personal questions. Obviously, everybody has been following your work. A lot of people wouldn't have known you from the whole heart disease stuff that we've all been involved in for a long time. But this huge curveball, has it taken a toll on you, on the family? Talk us through that.
Not as much as people might think. So I have a long background in corporate leadership. We've gone through some pretty hellish quality escalations where people are wondering if the plant will even close down. So enormous pressure. So that helped my corporate career. And also I've got two kind of rules, if you will, two motivators. One is truth in science. I've always been massively focused on truth in technical matters. It's a foible I have, if you will. The other thing I'm driven by are my 5 children. So myself and my wife are focused on the future for the children. I mean, I'll die, we'll all die. We're interested in the next generation. That's a massive motivator. So when people attack me over what I'm getting out, which is truth in science, reality, it just doesn't bother me because of my motivations. They tower over my opponents in terms of purity, if you will, not to be too righteous here.
I think people need to understand that this is you. You are the team. I mean, you've built your own studio here, and you've got, you know, government agencies and figures of authority on the run from your back garden. You're shooting, you're researching, you're editing. That's it.
Yeah, that's it. I have no one to delegate to. A couple of the kids do work and kind of keep Instagram going and do various things for me, but that's it. I'm primarily a one-man show, so to speak. So I do all my own technical sound, video, editing. I'm just one of those people who's so technically biased that I can generally pick up anything and do it. And in the technical sphere of research, I did a biochemical engineering degree. I worked for nearly 30 years in complex problem solving at the highest level, master technologist. So any problem I can go and get the data and analyze. You do not need to be a virologist, right, if you're someone like me, to go and research virology and look at the data and make a best case picture of what's occurring. Especially though, one thing I do have people, I have people in virology, epidemiology, immunology all over the world, in their thousands, who I'm networked with. So I always double check my research against people who technically do have the specialty. And that's how I make sure I'm never wrong. Welcome to the Fat Emperor podcast. I'm your host, Ivor Cummings. Huge honor today on the Fat Emperor podcast. We have our first and possibly only Nobel Prize winner. I'm here with Dave Feldman today, who many of you will know. Dr. Paul Mason, you have a new talk out yesterday with none other than Dr. Ron Rosedale. Dr. Asim Malhotra, cardiologist from UK. Dr. Beda Stadler.
The coronavirus is a group of viruses that... And the one we are so scared of, right, belongs to the beta coronaviruses. But also these viruses are quite numerous, and we don't know all of them. Some of them we know.
The coronaviruses are a family of viruses that have been around a lot longer than us humans. Although the symptoms may be similar, the flu is an illness, separate and distinct, caused by the influenza A or B viruses. The coronavirus family is typically known as the common cold viruses, although they may be severe or even fatal in people with compromised immune systems. Coronavirus disease 2019, or COVID-19, is the illness you can get from the SARS-CoV-2 virus.
During history of mankind, there were always coronaviruses that caused the problem, and then they mutated, they became less harmful, so they became basically just cold viruses, and then they turn around every winter or even during summer all around the world.
I live in Cape Town, South Africa, home to the late great Nelson Mandela and also to many of the world's great wineries. There are wineries in this region that are 300 plus years old. There's a fantastic agri-tourism business and agriculture. So it is one of the jewels in the world of tourism. Cape Town is consistently voted one of the top 3 tourism destinations. A very attractive place to live, but it has a dark side because South Africa is also the most economically divided country in the world. I was due to be in Ireland around now with Ivor to launch our previous movie, but of course that can no longer happen. So I decided to track COVID here in South Africa because I thought it would be interesting to see what would happen in a developing country versus the Western first world.
Well, I think this has certainly got everybody scared. We should probably compare this with the seasonal influenza, which has a case mortality rate of about 0.1%. So if we were to try to do a direct comparison, you would probably say, based on the South Korean data, the coronavirus, the COVID-19, appears to be about 6 times more dangerous.
Today I have Dr. Aseem Malhotra, crusading cardiologist and chairman of the Public Health Collaboration. Aseem, what was your initial reaction to the arrival of COVID-19?
My initial reaction was one of grave concern. By the time that COVID had hit the UK, I had already analysed data that revealed that the people who are most vulnerable after the elderly from complications of COVID-19 were people suffering from metabolic conditions. In other words, conditions related to excess body fat. And in the UK, we already knew that 80% of adults had excess body fat. So I was very concerned that we were going to have a big, big problem in terms of the morbidity and mortality in the UK from COVID.
In the beginning of 2020, numerous predictions of the death rate were made, from just a bad flu to millions of people would die. The Diamond Princess cruise ship was quarantined in Yokohama, Japan from February the 4th to March 1st, 2020, with 3,711, mostly elderly people on board. This incident gave Professor Michael Levitt an opportunity to formulate a prediction of the infection and death rates.
So for most of February, I was really focused on China and actually didn't pay a lot of attention to the Diamond Princess until my brother brought it up, I think around the 20th of February. He's more alarmist. I looked at the numbers, and at that time, we basically published total number of people on the ship, which was around, I think, 3,700, and that about 700 had been infected. And by the time I wrote my first report on the Diamond Princess, there were 7 deaths. So that is a relatively low death rate. Also, what was true was on the Diamond Princess, what I understood is that they were testing a lot. They had a testing group on the ship, and people were tested every day. But the number infected never got above, I think, 20%, 700 out of 3,700. The other thing is that I realized that if you take a ship and do a very simple calculation, you look at the area of the ship and calculate 4,000 people in that area, what is the population density? And it ends up being 250,000 people per square kilometer. And that is 40 times the density of Hong Kong, which is the densest place city on Earth. So I sort of said, well, let's assume that this is an attempt to get everybody infected.
By February 20th, extensive testing had confirmed that 712 passengers were infected with SARS-CoV-2, of whom 318 had no symptoms. 3 passengers aged 70 to 79 and 4 passengers aged 80 to 89 subsequently died with COVID-19. This implied a population fatality rate of 0.2%.
And that is higher than flu, but it's not that higher. And then we realized that the population is old. So it made me realize that this virus was actually not growing as fast as it should be. And I actually asked in this report a number of questions like, could prior immunity to coronaviruses be helping? Is lockdown, like in Wuhan, really necessary? And so on. Because my feeling then was very clear that this virus is behaving in a relatively benign way.
So Levitt was looking at around 0.2% of impact. Ioannidis from antibody studies, many of them, was looking at 0.15.
Yeah.
Ferguson was talking like 0.7 and much higher potentially. Ioannidis and Levitt were essentially correct. And that was clear. If you looked at Diamond Princess, you knew as soon as Ferguson published those predictions, you knew they were out by a factor of 10. There was no question about it. And sure enough, Sweden is a great example of Ferguson. With minimal measures, there could be 50 to 90,000 would die in 2020 by the summer. What actually happened was a few thousand died. And you can argue about the figures.
So there's no, like in the corporate world, there would be comeback. If you're so far out, like Graham Neary's done some great work here in Ireland. If Graham Neary was to predict a stock's going to do this and it tanked, you know, that's not great for his rep. There doesn't seem to have been any retribution for being entirely wide of the mark here.
No, there's none. And I think Ferguson is not being challenged in the least. He's not being dealt with for his insane predictions. There was a Spectator article last year, and I think it was entitled 6 Questions Neil Ferguson Needs to Answer. And they went through every one of his predictions over the last 10 or 15 years, foot and mouth, swine flu, and every one of them was orders of magnitude beyond what happened. But he keeps getting brought back into the picture. So in corporate world, Ferguson would be gone after his first debacle, which is back 15 years ago. Now, the other problem with Ferguson is he's in Imperial College. I think a couple of $100 million of contributions have been made by kind of vaccine-linked and Bill and Melinda Gates Foundation type outfits. And it just surprises me that an organization that's so massively conflicted and so hugely gets things wrong by orders of magnitude over 15 years continued to be brought front and center when there's a new problem. It's quite absurd.
One of the troubles with the coronavirus is it doesn't have a set of symptoms that allow it to be diagnosed as a disease in itself. So the symptoms of coronavirus overlap with lots of other respiratory diseases. So in order to identify something as coronavirus, you need a test which will identify coronavirus. And the test that's been most widely used is the PCR test. That stands for polymerase chain reaction. So the way that test works is to amplify small fragments of genetic material from the virus and thereby identify that that virus is present in a person.
A PCR test is performed to detect the genetic material of a specific organism, such as a virus. The test uses a powerful amplification process to make the viral DNA detectable and measurable. After a certain level, the test is so powerful that it can even detect the debris or remains of a dead virus long after infection.
Now, unfortunately, this test is very, very sensitive, and it's very, very sensitive to exactly how you do the test, whether it turns out to be positive or whether it turns out to be negative. Not only that, but the media and the government have conflated the idea of a case of coronavirus infection with a positive test. Now, these are two completely different things. In a normal winter, if you have a cold, you will probably go to work as normal. If you have a really bad cold, maybe you'll go to your GP and maybe they'll suggest you have a couple of days off. If you're actually seriously ill enough with your cold to require admission to hospital, then you become a case. Now, with coronavirus, we've suddenly reinvented the way we're thinking of a disease in a completely unprecedented way. In coronavirus, we've been counting every single positive test as a positive case. Now, this is scientifically and medically wrong. You can have a positive coronavirus test and be completely well. You can have a positive coronavirus test and be excreting minimal amounts of the virus. So to conflate positive tests with cases is simply wrong, and yet the positive cases have been driving government policy and the entire panoply of restrictive actions that have been taken.
Yeah, I worry about the cases that every day are announced by all our media, and everybody tries to push them up, and they don't come up really unless you increase the number of testing.
PCR testing, and I have a PCR lab, I know the technology, and this is 90% profit margin. The raw cost of testing is virtually zero. So the kit producers make profit, distributors make profit, laboratories make profit, and I think this is one of the reasons why people want to keep this going. Because when you have this huge amount of profit which just accumulated, you can easily use it to persuade some of the scientists or journalists to go your way.
Some people actually said that excess debt, the term, can confuse some people, even though it seems intuitive to us. But so excess debt, if you expect 1,000 deaths in July in a given region, and that's normal and that's generally what you see, but you see 1,100 this month, well, that's 100 excess deaths over what would be expected. And that's all the term excess deaths mean. And it's completely unbiased and you can't fudge the figures.
And you're absolutely right. The key thing, I mean, you basically, all the data that you have is total deaths from all causes. You don't, and even when you say excess deaths from COVID, all you're really saying is excess deaths in the COVID season. And this is exactly the same terminology that's used for flu seasons. Every single country monitors excess deaths from flu, because with flu, we're not doing the PCR testing. And the only way you can really tell was it a bad flu year or a good flu year is how many extra deaths there are over what you expect.
To measure the extra deaths caused by a war or disease, we must first understand how many people normally die in a year for the affected country or region. In Ireland, for example, more than 30,000 people die each year from a population of around 5 million. Therefore, Ireland's normal death rate is about 6,300 per million persons. By calculating the number of deaths per million persons, we can accurately compare the impact of COVID-19 across countries with very different populations. India, with a population of 1.4 billion, for example, has a normal death rate of 7,300 per million.
Nothing is more indicative of public health than all-cause death and, and populations. And these data should be publicly available for everyone. And I think this is something which needs to change.
Liz Piper from Reuters. I was just wondering if I could pose this question to all of you, really. I mean, how confident are we of the data, and how can we really know whether we understand the behaviour of this illness when we not necessarily have a chance to verify that data?
I think one of the areas that is going to be increasingly important going forward is the data that's used in my view, needs to be open so people can see it. That's going to be incredibly important as we go into looking at different areas of outbreak, incidence and prevalence in different parts of the country. Those data, I believe, need to be there for people to be able to look at.
Because some of the critique that of the science, which is entirely legitimate, and we are very, both Patrick and I and all of the people involved in this find the critique from the academic community very useful. I mean, the fact is, this is not settled science. Having lots of different scientific opinions is actually a helpful thing, provided it is expressed in a courteous and scientific way rather than just ranting. There is a bit of ranting, and you can work out which ones you think fall into which categories when you read what you hear.
Well, yeah, I have done my fair share of rants, especially on Twitter. And especially as this thing progressed and I became more and more frustrated with it.
I know a bugbear for you has been the censorship of scientists and perhaps factual science. Again, looking back through the prism of time, what are your feelings on that and where do you think we are today?
Yeah, that was possibly the most sinister aspect of this whole thing. So you never ever censor science. Science progresses through open debate and discussion. It's the death of science when you censor scientists. So that was actually one of the most horrifying things of all that I've witnessed. And for the first time in modern democratic free society, we saw this starting in March 2020.
The word on the street in South Africa was that this was going to cut a swathe through the informal settlements. And people in the first world don't really have an appreciation for, how we all live here. And the fact that you had people on top of one another sharing water, 50 people sharing a bathroom, this spelt disaster. Both the media and the authorities very quickly started to focus on the informal settlements as potential areas of danger and susceptibility to COVID. And Kailicha, as you leave the airport and drive into the city centre in Cape Town, it's an informal settlement of about 500,000 people. And this very quickly became ground zero for the fight against COVID, I would say, on the continent of Africa, not just South Africa.
In February 2020, the WHO abandoned their own previous pandemic guidelines.
COVID-19 is a new virus to which no one has immunity. That means more people are susceptible to infection, and some will suffer severe disease.
It's not fair to call it a new virus. You can call it a new member of the beta coronavirus family. That sounds different, but it doesn't create a panic if you say this.
That this is the biggest single challenge this country has faced since the war. The National Coronavirus Command Council has decided to enforce a nationwide lockdown.
The first lockdown in South Africa was particularly draconian. You weren't allowed to buy things like open-toed sandals, so no flip-flops. The beaches were closed. There was no alcohol, no tobacco for sale. It was a 100% shutdown of the economy. And in a developing nation, that's got to spell trouble. And everybody was stunned, but you couldn't really relate to people anywhere else what it was like. You really had to live it.
Lockdown, it's something which I always called a medieval approach. It's a very blunt approach because, you know, if you tell people social distance, you can say, okay, please don't go closer than 3 meters to somebody else. And then if things get better, you can say, okay, you can go to 2 meters or 1.5 meters. It's very hard to say how you lock down, keep everyone at home in a way that's soft adjustable.
Take us through this. I mean, you've been doing these updates throughout the coronavirus thing, but give us your overall perspective on where we've come from and where we are now.
Yeah, well, big story. So really starting off, I was looking firstly really at the Italian data and the initial kind of where Europe got hit, because China was always questionable, we weren't really sure. And when Italy started getting hit, I was looking at the numbers, and it seemed to me that they hadn't prepared. I had been saying publicly that this is going to come, right? Italy's seeing cases. So why aren't we protecting the most at risk, like the care homes, the elderly? And then, of course, just taking a bird's eye view, when the deaths started really happening in each of the countries, then they began to do lockdowns. And that's where I said, hold on a minute. The distancing will make a difference. The lockdown, because it's going to be so prevalent already, is not going to make much extra difference. And now you're going to get all the negative impacts with no payback. So that was kind of a bird's eye level view of where I went through it. In March, I interviewed Tucker Goodrich.
Lockdown and quarantine is an effective mitigation when nobody's infected, right? I mean, it's, they knew this in medieval times. If the plague is around, you draw up the drawbridge and don't let anybody into your city. And, obviously, if you're not in contact with anybody who's infected, you're not going to get the disease. That's pretty basic. The problem is, if you look at those interventions, once you have the disease already in a population, especially a disease that's as infectious than this, it's just not an effective intervention. And that's what the literature shows, going all the way back to, I found a paper from a textbook on communicable diseases from 1948 that said, it just doesn't work once the disease is in your population.
So the numbers were telling us what we felt, that the lockdown was too late and wouldn't add much more. But since then, what have we got? We've got the orthodoxy, the media, and all of the experts telling us that lockdowns are great and we need to keep going. None of them that I can see have done any analysis of the data. It's just faith-based. And a week later, which is a few days ago, the Israel Prime Minister announced pretty much the end of the lockdown, and kids can even see their grandparents. How can you have a lockdown, which in Israel was very severe for 5 weeks, still have loads of prevalence of the virus and then stop doing it? I mean, what did the lockdown do if you can just stop doing it and you're not worried about it going up?
Exactly.
So I'd say there's myriad points now, not proof, but myriad points, and many professors who are saying what we're saying, that the lockdown doesn't add to smart distancing. But no one wants to hear that.
The main strategy would have been to protect the vulnerable people. And every country who doesn't do it pays the price now in mortality.
Another risk is that recessions kill people. When there's a recession, the death rate goes up. The life expectancy goes down by more than a month. So a hard recession is certainly more dangerous than COVID-19.
We were all sort of plunged into this abyss, and as I tell our team, we're all navigated this for the first time. Nobody had the kind of experience you needed to navigate COVID. If you take tourism as probably one of our most apex industries across sub-Saharan Africa, for every person that's employed in tourism, about 10 people directly benefit from that tourism job. And that really impacts what happens to wildlife and that. So poaching and all these things are direct relations to what economic activity looks like within rural areas. And they've been really hammered by the fact that we haven't had any international tourists coming into our reserves. So we took the hard decisions up front Right in April, we tackled this thing as though it was going to be long-lasting. We restructured the business, we took the painful decisions, the hard decisions, and we geared all our decision-making around survivability. So we built 2-year survivability plans if this thing was going to last, because making sure we were here on the other side to look after our guests and go back to serving our purpose was very important to us.
The cost benefit of lockdowns is catastrophically negative, and we're going to see it in the coming years. The economic determinants of health, the unemployment impacts, the depression, which often people never get out of. They go into a spiral. The cancer cases missed, right, in diagnosis, coming late. I'm hearing a lot about that, and cardiac issues. So we've got this massive kind of freight train of negative impacts coming, and sadly, I suspect that the people driving this thing will A, never admit that, and B, will try and attribute problems in the coming years somehow back to the virus itself, or God knows, back to the unvaccinated. You know, we're going to see a lot of duplicity and a lot of fraud. I know we've seen a mountain already, but in the coming year or two, we're going to see revisionism and reattributing causes to things that they were not. It's going to get crazy in the next year or two.
Very clear evidence from the UK and around the world that children much less commonly get severe illness, and they end up having to be hospitalised if they get symptomatic COVID at probably a rate of less than 1/10 of that of the general population. And there's some evidence that children, particularly primary school children, are actually less likely to catch COVID in the first place.
But I can announce today that after schools shut their gates from Friday afternoon, they will remain closed for most pupils, for the vast majority of pupils, until further notice.
Yeah, the school closures made no scientific sense. From very early on in mid-2020, we had an Irish study showing minimal possible effect from schools on transmission or impact. We had a study out of Sweden, similarly with teachers and kids. And we also had a study, I think, from Denmark, and many, many more. So it was clear scientifically that closing schools was not a good policy. If anything, you should allow more community immunity to help granny later. It made no scientific sense, but then a lot in this issue didn't.
One of the great challenges of COVID everywhere was to make sure that people who were exposed to not just COVID but other illnesses and diseases were getting the medical support that they required. The lockdown in Kailicha was very different from a lockdown in, let's say, the middle and upper class societies in South Africa. That basically forced people on top of one another. So if the strategy behind lockdown was to isolate and social distance people, that did not work, and in fact the opposite happened. The focus on Kailicha was strategic, and a big part of the reason was that there were tremendous resources already operational in that area. Médecins Sans Frontières helped build the very first field hospital in South Africa. Because of the history of HIV and TB support and research in Kailicha, it meant that the authorities had a fantastic data set. So as COVID hit, they started to profile the people that were most at risk, and they turned out to be the elderly, the frail, and the type 2 diabetics. What was really interesting, at that time, the authorities began a full-blown medical intervention. Every type 2 diabetic in Kailicha was in direct contact with a doctor on a daily basis. And of course, people here would have typically gone to the clinic to receive their medication. That was no longer possible. So in Kailicha, the authorities very quickly commandeered a supporting network to get medications delivered door to door throughout that entire area. And I think people need to understand that the resources that mobilised in that informal settlement were absolutely world class.
We say no lockdowns anymore, ever.
We don't generally recommend the wearing of masks in public by otherwise well individuals because it has not been up to now associated with any particular benefit.
The recommendation from SAGE is completely clear, which is that there is weak evidence of a small effect in which a face mask can prevent a source of infection.
The evidence on face masks has always been quite variable, quite weak, quite difficult to know exactly, and there's no real trials on it. And we will undertake a review, we'll give our advice to ministers and they'll make decisions about what to do around that.
We are guided by the science, and the government position hasn't changed.
I can announce that as of Monday the 15th of June, face coverings will become mandatory on public transport. That doesn't mean surgical masks, which we must keep for clinical settings. It means the kind of face covering you can easily make at home.
Let them breathe! Let them breathe!
You should be embarrassed and ashamed with the agenda that all of you are letting happening in this town.
Anyone harassing me to wear a mask, you guys are violating federal law. Do you get that? Get that on camera.
At the outset of all of this, you fancied the masks, let's be honest. And you've been pulled up on that.
Yeah, I did, because I saw the Taiwan early work on, laser interferometry and particles, and I didn't know much about that transmission kind of situation. But the problem is then I looked up 40 years of science where they actually did proper studies en masse for influenza-like transmission, and the answer was clear: no real benefit. The reality is we have the R curves for 5-6 countries now where a mandatory mask came in at different dates. And for every country, when you put the date of mandatory mask, whether it's Czech Republic, Slovakia, we have Scotland now, Germany, there's a couple more. The mask mandatory came in at all different dates. The curve never changed at all, the R curve, nothing. And that makes sense because 40 years of science have been unanimous pretty much that for influenza viruses, surgical masks and coverings are just very ineffective. So it agrees with the science. It doesn't agree with the science of June 2020. I saw a flurry of papers came out saying masks could be good, and they were overwhelmingly associational and modelling papers. So a few weeks of papers have overturned a few decades of accepted scientific sense.
If masks would work, you could throw a mask in a country and then you would immediately see a peak, how it goes down. Within 14 days, you would have to see a dramatic change in the curves.
And then we had Danmarks, the only randomized control trial, which masked a bunch of people and non-masked. And that came up with the same answer.
We tested if face masks would reduce the rate of infection by 50%. That is when a healthy person wears the mask, on top of what we are otherwise recommended to do, that is mainly to keep the social distance and take care of hand hygiene. Such a great reduction in infection rate wasn't seen in our study.
Would that study have hit the headlines if it had found benefit?
If Danmark had found benefit for masks, it would have been all over all news outlets, all over the world, within a day or two. but it was actually suppressed and no one wanted to publish it for a couple of months. And eventually when they published it, the wording of the authors had been changed to say, well, we didn't find anything, but we still think they might work. I'm not joking you.
If we are looking at it, it seems we have a small degree of protection of masks. That is the conclusion from our study.
As the first wave gained momentum, it became very clear that it was correct to focus resources on Kailicha, but the other 9 provinces in South Africa started to meet COVID head on, and that's when we saw the numbers start to climb. The authorities were very good in sharing open information on the case rates and the death rates, so we were starting to get a picture that this thing was spreading right throughout the continent. And in fact, Kailicha, when we tracked it, it didn't really do any better or any worse than anywhere else in South Africa. And that was probably the first great surprise here in South Africa. COVID came, but it didn't just come for Kailicha.
The immunity term is being thrown around quite loosely. So what does it mean for A, an individual, and B, for a population?
There is no difference between population and individual. You are either immune or not. And you can have different degrees of immunity. You can be just a little bit immune, or you can be strongly immune against something. And that merely depends on how many times you have seen the foreign particle, or in our case, it's what we're talking about, the pathogen. So if you have seen the pathogen multiple times, then you are more immune.
The immune system has 3 defensive layers to protect you from a virus. The first is in the mucous membranes. The second is the T-cell layer. The T-cells have a long-term memory of previous coronaviruses, which can help them identify and respond to a similar but new coronavirus. The third and final layer comes into play when antibodies are released from your B cells in response to the viral attack.
T-cells are the ones who can look into cells if a virus is sitting in there. So people have used T-cells and they have given them peptides, synthesized peptides, different lengths from the virus. And then these T-cells got excited, started to proliferate and so on. That's then measured as a T-cell immunity. Second, if you have a T-cell response, you always have a B-cell response. B-cell response means producing antibodies. You cannot separate them. You cannot have exclusively T-cell response and no B, or vice versa. So, and the B-cell response is antibody levels. That's something that's now slowly coming up, because these tests are much more difficult to do than a PCR.
They say that natural immunity has been forgotten or even denied in this pandemic, but you wrote a book specifically on that whole area. So what would you comment on that one?
Yeah, I think it has been forgotten. It hasn't been well explained. Certainly, we know that lifestyle, whether it's even doing regular physical activity, does enhance T cells and the immune response. We know, for example, that people with type 2 diabetes that had poor blood glucose control admitted to hospital had a 10-fold increased risk of mortality versus the type 2 diabetics with better glucose control. And that's all related to what people are putting in their mouths. So there's a lot of very plausible, good biological data how lifestyle can improve and enhance natural immunity.
When a population has been infected by or vaccinated against an infectious disease in large enough numbers, this is herd immunity.
Herd immunity is a strange expression. It means that is at a certain level where it gets too complicated for a pathogen to jump around. With every jump it does from human to human, if it risks that the jump is for nothing because the aim is already immune, then slowly a herd immunity is installed. So that can depend on the pathogen. That can be a few percentage, or, for example, for measles, it's very high. It's above 90% that you have to, of the people that have to be immune, really. So, but for other organisms which have which are less harmful, so to say, usually 40 to 60% is a figure that tells you that herd immunity is reached. Herd immunity, you can only measure it once it has happened. You cannot predict it, by the way.
In August-September 2020, the Northern Hemisphere braced itself for a potential second wave. The last couple of weeks I've been putting together some data, and it's been very interesting in Europe in the past 4 to 6 weeks that there's certainly an increase in cases and, to be honest, testing. But when you look at the first impact of this, and it was like you say, it was quite severe. The cases, there's a huge curve upwards and down, and then the mortality lagging, there's a big curve upwards and down. But what's striking in the last 6 weeks in France, Belgium, UK, Ireland, all over Europe, there's now a big rise in the cases, but almost nothing in mortality or ICU, or just almost nothing. So we've got a wave of cases for sure, or positive PCRs, but we're certainly not getting a wave of actual impacts. But that's the question then, when or why would the impact start rising for a virus that's already passed through the population and taken the susceptible and caused a lot of community immunity? When would an impact start rising, a true second wave?
Yeah, I think that's absolutely right. And I don't think any health professional would sit here and say they can predict exactly what's going to happen in the winter. But I think we have to be really cautious in the light of what you've just said about these Armageddon scenarios that have been put forward of the likelihood of seeing a second wave that's bigger than the first wave, or even the same size as the first wave. We don't know what's going to happen in the winter. We may see local outbreaks. We may start to see an increase in the number of cases. But most health professionals on the front line that we've spoken to, having gained their learning over these past several weeks since cases started to increase, is that actually that is really pessimistic. And the likelihood is that we might see a few more cases in the winter, but it's not going to be as horrific as we expect.
In terms of this winter, the prior SARS or coronaviruses had one wave and it was much smaller in the following season. So there is prior knowledge that coronaviruses in the second season, after it's hit in the first season when you have the most susceptible people and then they sadly pass, that the next season will be relatively much lower in impact. So we can kind of leverage
with one assumption, and this assumption is that you infected majority of population.
Yes.
So what happened this time is that the big part of the world went into lockdown and not so many people got infected.
So if the lockdowns don't work, how can that be the case? What Gordon has just said.
Well, Gordon was working with what he had at the time, and I even thought there would be some efficacy of lockdowns, some suppression, and I spoke about that in my September video, that if anything, if you achieved some suppression, it would make things worse later. It turns out at the end of the day, Donal, that we even overestimated the potential effect of lockdowns. I think it did spread much as it would have spread without lockdowns.
The second wave in South Africa was very interesting for a number of reasons. It struck during the summer season, which was kind of unexpected because we all thought and had been told that COVID was seasonal. Well, here it was, midsummer. And the big news really was the emergence of the beta variant, which was first known at that time as the South African variant. But of course, they now know that that variant was in 50+ other countries at the same time. But the very good standard of scientific investigation and rigour here in South Africa just meant that they found it first.
A variant is the most normal thing for a virus. Some of these mutations may be silent. So you have 1 or 2 nucleic acids which are changed, but they do not matter. And others you can see are larger changes, for example, but they can still infect the same species as before. So now we speak about the variant. It's the mutated virus which still has more or less the same species that it can infect.
Would you consider the variants to be geographical?
Yeah, a mutation always starts at one place. But if in the genome, it's a very susceptible part of the genome, the very same mutation can happen in different countries, more or less at the same time. It's just a matter of time when such a mutation will occur. So it's not fair now to give all these variants geographical names, because as it was unfair to call it Spanish flu or whatever, Hong Kong flu, you know, it's just coincidence that it was found there, you know. A seasonal virus is actually a wrong expression. It's not the virus who is seasonal, it's we are seasonal. If we change, we become infected by a virus because we have the receptors.
But we never test for influenza or for coronaviruses in the middle of summer, so we don't see them. And actually there was one episode of testing, and this was 2009 H1N1 influenza pandemics, when in UK there was a lot of testing in the summer and they were seeing the virus. So virus was there, but people were not severely ill. So obviously, there are many aspects of seasonality. We cannot say that if the virus is seasonal, that it will not exist in summer or that it will not exist in the tropical areas. And we see now that the SARS-CoV-2 is spreading also in the tropical areas.
So as that second wave progressed here in South Africa, it became very clear that, in Kailicha at least, the virus was starting to behave as you would expect, because their second wave was significantly smaller than the first. There were less deaths, it had less of an impact. And of course, this is what Professor Stadler had told us to expect. A virus will dilute and it will become weaker. Personally, for me, the second wave felt like the first wave, because I started to see COVID spread right throughout my social network. I didn't know anybody who died, but COVID was spreading amongst the middle and upper classes here in South Africa.
Basically everybody, over 90% of our population, has already some degree of immunity. So if you come now with a vaccine, this immunity, you can increase it a little bit. But even though in Switzerland, people call me the vaccination pope, you know, so, because I'm so for vaccination, and I am. But I always fighting against our health officials, because they say for the flu vaccination, all the risk, people should get vaccinated. And always, I say always, this is not fair. The people who have no immune system or a weak immune system, it's almost impossible for them to become immune because their immune system is so bad. That's for the flu. And now look at the corona. Who is dying? It's those people who have a miserable immune system. And those people would have to be immunized now. I have never seen a vaccine that is so good, that can really immunize those people. I've never seen it. It doesn't mean it doesn't exist. So, but the first thing, if a vaccine comes, we should look, does it work in the patients at risk?
I think the other thing to add in, which again was missing, and something I wrote about in my book, The 21-Day Immunity Plan, is if people with obesity related to many other vaccines have a depressed response to the vaccine. So actually, there's another reason to improve metabolic health, is you're much more likely to get a better response, a more robust response to vaccines if your metabolic health is optimized.
Yeah, Stadler, Asim, and all the others are broadly correct. So the history of influenza vaccines, and these ones you could argue are less capable because they don't have the full virus. It's very hard to reach and protect the people who are most at risk because they're already immunocompromised, so you're not going to get a good result from the vaccine. And that's why we're seeing one vaccine, second vaccine dose, and now they're talking third vaccine dose. What kind of vaccine needs 3 vaccinations and maybe a 4th and more within months? And the answer is a vaccine that's not really working very well at all.
When the issue of vaccines started to gain momentum, it was interesting that that was something that was happening in the first world, because it certainly wasn't happening here in South Africa. The war cry at that time was nobody is safe until everybody is safe. But that wasn't the case at all, because although many of the vaccines were actually researched and developed here in South Africa, they were shipped overseas for consumption in the Western and First World. The COVAX program, which was designed and funded to send vaccines free of charge into developing nations, utterly failed. In addition, Pfizer came to South Africa and demanded that state assets should be put up as a vaccine insurance fund. So not only were they not prepared to deliver vaccines into South Africa on an equitable basis, they actually wanted the country to put state assets on the table as an insurance scheme. And I think that really shone a light for me on the fact that South Africa and many developing nations are in fact nothing more than PR opportunities for the Western world. In August 2021, 18 months after I had first travelled back to South Africa, the back door opened for me to travel back to Ireland.
Normally this is just a quick hop. You jump on an overnight flight, you get a connecting flight to Belfast or Dublin. That's it, you're back to base. However, the UK and Ireland are both retaining their red list status on South Africa. We're in the middle of our so-called third wave right now. As a result, I will be flying to Slovenia. The only requirement there is a rapid antigen test. So I've got to get a PCR test here in Cape Town, which will allow me to board with Turkish Airlines. I then get to Istanbul Airport, where I've got to get a rapid antigen test. And assuming that's a negative, then I have free and open access to Slovenia, where I'll spend 2 weeks, which washes out the red list South African status, means I can fly openly to Ireland. So that's how difficult it is for me to get back to Ireland at this time.
I came home. I had taken all the various tests to board flights. I found that when I landed, nobody checked anything in Dublin Airport. And remember, this is the country that has experienced the longest, harshest lockdown in Europe. So you land in here, nobody checks anything. That was remarkable to me. For the first 10 days, I didn't get to see any members of my family, apart from my parents. My 2 older brothers had actually contracted COVID. And what was interesting about that was the fact that the virus eventually reached my eldest brother. He's not vaccinated, but he contracted it from my next brother who is vaccinated, and some members of his immediate family who had also been vaccinated passed it on to him. So it went through, I believe, 6 or 7 vaccinated persons before it actually got to my brother who was unvaccinated. We now know that the vaccines that have been used to date, Fauci himself has admitted that the viral load in somebody vaccinated is exactly the same as somebody unvaccinated.
Do you mind the days we used to argue about the benefits or not?
The one thing I've noticed now that I've come back home here, and COVID is everywhere, it's quite remarkable. But interestingly, my wife's cousin in Cape Town got COVID, mild case. The doctor was on immediately. They're prescribing cortisone and a batch of medicines to immediately treat the disease. And here, the brothers, their families get it, and you're just told, okay, stay at home for 10 days. The next time you appear on the medical system is if you present in hospital. I mean, it seems utterly ludicrous to me that not only are they disregarding what might be possible therapeutics, they're not even attempting to intervene at any point once you contract the disease.
The fact that the authorities are not interested in treating it per se. But I think we go back to March 2020 and it came down from the top that there was no treatment for this, effectively. I mean, there was some steroid treatment, and then there was the debacle with the ventilators where they pretty much nearly admit that many people died in New York, might not have otherwise because they were overzealous in the use of the ventilator. So it was pretty much again set in the narrative. There is no treatment. There are no treatments until we get the vaccine. And that trickled down all over the world. So South Africa are using treatments. India were using treatments. The countries that are not being focused on or too under the boot of the narrative, they tend to go and do the right medical thing. Let's try and treat the people. But in most of the Western countries and the countries following the narrative very powerfully, it's exactly as you say. If you get COVID, we're going to pretty much do nothing until you end up in the hospital or an ICU. And then you become a ICU or hospital stat.
Right up to date now, the reports out of the US are saying 99% of people in hospitals and ICU are unvaccinated. That's not quite the full story.
Yeah, there's a lot of trickery with the data. So the Israel data showed pretty clearly that the cases across all age ranges were the same level for vaccinated and unvaccinated. The hospitalizations are difficult because you can't get the raw data, and they're very confounded data. In one case a few weeks ago, the US came out with shock stories of 99% are unvaccinated. However, they were counting from way back in the epidemic before the vaccines were available. So the lion's share back then were unvaccinated because the vaccine wasn't here yet. So there's a lot of trickery, I would say fraud, in the way the data is being presented. There's another problem that they're calling one-shot people unvaccinated. So one shot, there's been a certain amount of evidence emerging that after one shot, you may have a higher chance of coming up as a case, and you may have a higher chance of having an issue. And in those cases, if you put the one-shot people in with the unvaccinated and call them all unvaccinated, you can bias the data again to look like more unvaccinated proportionally are in hospital. There's also another problem that what they're seeing in London from an ICU specialist I know, yes, there's a majority unvaccinated, but overwhelmingly they're obese or immunocompromised people. So still, even if there are more unvaccinated there, you're still back to the same reasons why, right? Obesity, very big obesity, and immunocompromised people. But that just brings us back to the same point. We should be focusing on the susceptible people and strongly suggesting they take the vaccine. But what's with the mandatory for everyone? And what kind of sociopath would go after the children?
It's not needed for children. Never a child below 10 has died. So I wouldn't immunize children. Well, why the heck? I mean, they are protected.
We are headed into a very dangerous area.
Receiving the jab is not mandatory in South Africa.
Are you saying me I'm an idiot? And what do you think you are?
No arrests have been made. Both sides blame the other.
I think after 18 months, you know, Sweden started out the star of the show, or was it? But if we look now at excess deaths here, from the beginning to where we are right now, what's your read on it?
Yeah, well, Sweden turned out, as I expected back in April, May 2020, Sweden was crucial because they were a control country. And in science, you must have controls to find out what the truth is. So Sweden, as we can see here, overall, there are a few hundred people per million in the population of extra death over what you'd expect. They performed far, far better than the UK, which is well over 1,000 per million, and they came in the lowest third of Europe in extra mortality. So they're doing incredibly well, and I guess they proved what Tegnell said. Judge me in mid-2021.
You said, judge me in a year. So it's been a year and a couple of months, and here we are. Were there moments when you thought, have I got this right? Do I need to change course?
Not really, and that's mainly because it's not really me. I mean, we're a group of people discussing this continuously. We also have a lot of contacts outside of the agency with other experts, where we discuss this continuously. And I think we were fairly much in agreement that, and we saw that they had effect. Of course, we would have been much happier if we didn't see the high death toll and the crowded hospitals, but we managed to keep it into some kind of reasonable level. And I think in the end, do understand that we did the best we could in the situation we had.
So they aced the game, if you will. And they had no lockdowns, no masks, and kids up to 16 years old in school. That's it.
Northern Ireland is experiencing a very high rate per million at the moment. The papers today suggested it was the highest in the developed world. So it's worse than South Africa if you look at data, cases per million, deaths per million, etc. And yet South Africa remains under the kibosh, very much red listed.
The Minister of Health in the UK, I mean, he basically just threw us under the bus, is what he did. Didn't want to take responsibility for his own numbers, so threw South Africa under the bus.
I understand the enormous sacrifices that everybody in this country has made, that you have made, and those of us who make these rules have got to stick by them, and that's why I've got to resign.
As the world comes out of the third wave, I think the most remarkable thing for me locally here in South Africa is to see the success of Khayelitsha, because as Delta cut a swathe across the world and indeed South Africa, it was bigger here than any of the prior waves or the variants that we had seen. But in Khayelitsha, that 68% level of antibodies across the community proved to be extremely powerful and very, very protective, even against the new Delta variant. So while the UK was in complete disarray, here we had an informal settlement in an economically deprived region with a population of 500,000 outperforming the UK and many first world nations. They did that not because it was planned, but they did it because focused protection was on the table from the very outset. The authorities did a great job protecting the vulnerable. What they had not intended was for COVID to spread throughout the community. But in doing so, they arrived at a point where herd immunity, if you like, had been reached through those methods that we would have traditionally proposed. And that 68% level of antibodies in the community was reflected elsewhere. We saw it in India, we saw it in the Orthodox Jewish community in London, and we saw it in the Amish communities in the USA. So when this virus was left to behave in a manner that would allow it to spread amongst the healthy, they were typically getting to about 2/3 of the population displaying antibody levels. And the question, of course, was, is Professor Stadler right? Does immunity from prior infection, even if it's a different variant, is that superior to protection from the vaccines? Because the consensus at the very outset was that vaccination was the only way out of the COVID grip.
is this an epidemic of lifestyle?
Yes, I think what we've had is we've had a fast pandemic in terms of COVID that has exacerbated and taken advantage of a slow pandemic, which is the pandemic of chronic lifestyle-related diseases that have been putting stress on our healthcare system for many, many years. And our NHS, certainly even before COVID, was already at breaking point. But actually, COVID has broken the back of the NHS. And the main reason behind this is because we've failed for many, many years to tackle prevention head on, specifically the biggest driver of these chronic disease, poor diet. I mean, ultra processed food, which is the heart of the problem, is now half of the calorie consumption in the British diet. It's about 60% of the calorie consumption in the United States. And there's a very clear correlation, as we know already, with countries that had more than 50% of the population overweight or obese, had 90% of the deaths from COVID-19. So poor metabolic health means poor immune health. But beyond this, we know that the real drivers of this problem are structural. These are to do with the environment and to do with misinformation that is being subjected on the public for the purposes of profit. And the two real culprits behind this, in my view, are the food industry and the pharmaceutical industry. And the collusion of academics, medical journals, doctors, and politicians for financial gain with these industries is at the heart of the problem. This needs to be exposed, and the public need to understand and realize that two of the biggest enemies of democracy are the food industry and the pharmaceutical industry.
Eilish, has this man driving you mad over the last year and a half?
Oh, he's been our rock. He's been fantastic.
Is he?
Yeah. If only for Ivor, like so many people say, that we all really appreciate.
A lot of people have commented that you've kept them sane, but what, in your opinion, is your greatest achievement over the last 16 months?
I think it's to bring some rationality, logic and science back to the proceedings, because the conch has been owned by the narrative side, and I think things have been twisted beyond belief on most vectors of this. Most aspects of the science, believe it or not, have been twisted remarkably. So just to kind of, on each time or each aspect, when stuff comes out that's misleading or obfuscating, that I can quickly research it, use my vast network, and quickly get out a very understandable message for ordinary people that puts it in context, proper context, and explains what the reality is. So yeah, I've been inundated with emails and messages from people who said, "You've saved my sanity." And it's funny how many say that. Originally, one person said to me, you know, by telling people what's really going on, it might make them more depressed, realizing what a debacle this really is. But it turned out in the end, no, that didn't occur. People were delighted to know the reality, see the real data, see things in proper context, and realize they were not going mad, as they instinctively thought, what is going on here? You know, they at least knew, okay, it's some kind of corruption or bias at the top. I don't know exactly what it is and why it's all over the world, but at least I know I was correct. I was not going mad. A key thing to remember, I think, is that if you turned off the media, no one would know there's an epidemic. You know, even during the surges in Ireland, in both seasons, if you did not have access to the media, you would never know. No one really knew anyone who died. Outside of the odd person, someone in a nursing home or of elevated age or with stage 4 cancer. But most people did not know anyone who died, right? Isn't that incredible in a massive pandemic, as we are told?